Okay.
Oh, there you go.
There we go. Perfect. So I'll wait and let people start coming in.
Yeah, it usually takes a couple minutes for them to kind of filter in.
Hi, everyone. Welcome. We're just going to wait a few more minutes to let other people come in. I still can't believe the snow outside. It's insane.
Yeah.
I know, another snowstorm this week. It's just
no. Oh,
not
like
typical.
this week, yeah.
I think it's been like 25 years since we had a snowfall like we did a couple weeks ago.
Yeah.
A really long time.
Yeah, I think I was reading in the newspaper, 1993 it said, or something like that.
Yeah, that's what I heard from someone.
Yeah. Yeah, we were like the laughing stock of the country, because Mel Lastman, who was the mayor at that time, called in the military.
Oh yes, that's right. Someone else told me that too.
Yeah.
It's funny. We're like heroes compared to South Carolinians. They're like, what? You still like function in this? Like, I think they got 3 centimeters, and they shut down school last week for a week.
Wow.
So how often do they get snow? Like, is
very
it not
rarely,
typical?
like twice a year, maybe.
Right. Yeah, it's all about what you're used to dealing with and how
It's
well
so
things are
funny,
set up to deal with it, right?
So funny. What do you guys think? Should we get started?
We've got 24 people in. There were a lot more registered.
Do you want to wait a bit?
I would maybe wait just a couple more minutes just to make sure.
Sure. I have, I think 29 now, but it's a good idea. We'll wait for a few more people. Usually people are about 5 minutes late.
Wonder if it's worth, if as people are joining, if they have any top questions they really like to get answered, they could always put it in the chat, and then as
true.
you guys go through, you could have those in the back of your head.
Yeah,
that's a great idea. And Jen, we can monitor the chat for you, so if we see questions, we can sort of tell you and let you know what they are, and you can address them. Okay,
that'd be great. Let's see. Does anybody have any burning questions? Good, we have a few more people. We'll give it another minute.
Yeah, it's kind of slowing down in terms of the numbers that are coming in. So I think another minute will be great.
Okay.
And then we can go. So we have one question just about treatment options and success rate, which I'm sure you'll get into. And
okay, perfect.
Into the presentation.
For Lucy, who asked that question, if she could even give us a little bit more context around vestibular rehabilitation as a whole, or if she has a certain condition, how treatment options and success rates are. That would be great. All right, perfect. So I'm going to go ahead and get started. So welcome to the vestibular webinar on conquering your dizziness, balance, and vertigo in collaboration with Vintage Fitness. Vintage Fitness is an excellent resource providing in-home personal training for individuals 50 plus in the GTA. Our presentation today, you will hear from myself, Jennifer McConvey, and you will also hear from personal trainer Christy Belanger from Vintage Fitness, who will also, I'll introduce you to you shortly. All right. So I want to start off the day by asking the question, if you had no dizziness, vertigo, or imbalance today, what are the things that you would be doing? So I want you to type in the chat. So I want this to be interactive as possible. Just feel free to jot in there anything that comes to mind. Picking up my kids, running around with my grandchildren, anything like that. I want to kind of keep our eye on the prize here, or the goal of the presentation, and that is for us to be able to provide you with some excellent resources of what you can do for your dizziness and balance. So go ahead, if you have any thing that you want to put in the chat, you can. Right. And then make sure that when you put, when you type in the chat, put the filter as going to everyone. That way we can all see everyone's answers, questions, or comments. All right, I'll go ahead and move along. So rules for today: have fun, be interactive as much as possible. We're going to give you 110%. And hopefully by the end of this, you're going to feel inspired to take some action. That could be through our e-booklet that we have that you're going to be getting at the end of today's session. It's also, you can take action by booking a free 15-minute scan with us, or going ahead and booking a full assessment. So who are your presenters? Who are we? So my name is Jennifer McCombie. I am a vestibular physiotherapist. I have about 12, 13 years of clinical practice in the realm of vestibular therapy. I've completed multiple post-grad courses to become a vestibular therapist. I am a vestibular health provider with VEDA, which is the Vestibular Disorders Association. And I also sit on a few advisory boards here in Toronto. And I'm going to let Christy give you a little bit of info about herself.
Hi, everybody. My name is Christy Belanger. I'm a personal trainer with Vintage Fitness. I've been certified for over 10 years with CanFit Pro. I'm also a certified exercise therapist, level 1 and 2. So I help people with injuries, post-rehab. I'm also certified with Functional Movement System, level 1 and 2. So just helping people move better and more functionally through life. And I'm also a certified sports nutritionist with the YMCA, and certified AED and CPR. Perfect. So happy to be here. Thank you.
Yes, thank you, Christy. All right, so I want to start off to talk today about how dizziness is more of a broad term. So a lot of people come to me and saying, oh, I have dizziness, but actually dizziness can mean a lot of different things to a lot of people. So you could have dizziness of the room is spinning around me, or I feel my environment is moving a bit, or I'm moving. And that could be a term called vertigo. So it's great to use that term vertigo if that's how the feeling that you're getting. Because that could be something totally different than someone saying, oh, I feel like I'm going to kind of pass out. So like feelings of syncope. So it's great to kind of break down these terms underneath the umbrella of dizziness. So like I said, vertigo, or having syncope, or being imbalanced where you feel unsteady. You can also have something called like disequilibrium, where your head is kind of disconnected from the rest of your body. So it's really, really great to really kind of tease out some of that and make sure that you're telling your healthcare provider or whoever you're talking to kind of the correct terminology. The best thing to do too is kind of not use the word, describe your dizziness without actually using the word dizzy. So again, why is it important? Because describing your dizziness will help your provider perform the right test, refer you to the right people, and ultimately diagnose your problem in a more quick and accurate manner. So on the right here is what I like a lot of my patients to fill out before they come see me. It kind of teases out characteristics of your dizziness that helps me kind of dictate what we're going to do in the initial assessment, what tests we're going to perform, and all those things. It gives me clues to kind of figuring out why you're getting dizzy and how we can help you.
Just a quick question, Jen. The attendees are going to get a copy of that questionnaire, right?
Yes, so that's a great question. So yeah, they're going to get a copy of that in their e-booklet at the end of today's session, so they can kind of go work through that in their own time. That's a great question. So there are many causes and reasons for dizziness. So let's start with the cardiovascular system. So one can get orthostatic hypotension, where when you stand up, you feel like you're going to pass out. And that's with like blood pressure regulation and different changes of position. So that would be more along that line of describing to someone, oh, I feel faint. I feel like, and it's always right when I stand up or right when I sit up from lying down. Stroke is actually a pretty rare cause of dizziness. Less than probably 2 to 3% of individuals experiencing dizziness are due to stroke and causes related. But usually if you're experiencing something like that, you would have other symptoms such as facial numbness, weakness, one-sided weakness, stuff like that. Other cardiovascular involvement could be heart arrhythmias that could also cause dizziness. From a neurological standpoint, things like multiple sclerosis can mimic a vestibular disorder and cause dizziness. So that's why it's so important to have a really comprehensive exam. Migraine can also cause dizziness, especially there's something called vestibular migraine, where is someone from the past that had regular migraines and really like presented in with a headache, a really strong headache and stuff like that. But then later on in life, the migraine is kind of switched into more of a vestibular component, where the dizziness and vertigo and imbalance are the main components of the presentation for the migraine. Medications always come with multiple side effects, dizziness being one of the top ones. You almost see it on every side effect bottle. So it's really great if you are experiencing dizziness and an onset when you've recently onset with a new medication, to talk to your doctor about that. On the right side here is a lot of the systems that make up your balance. So your vision, your proprioception, which I'll talk a little bit more about what that is, and your inner ear. So we're going to go on to the next slide so you can get more in depth with that. All right, so vision, proprioception, which is the input that you're getting from your feet and mainly your neck, the joints and the muscles that are telling your head where you are in space. So that's proprioception. And then you also have your vestibular system, which is in your inner ear. These three systems are constantly talking to your brain to tell you where you are in space, how to balance and all those things. So your brain's constantly receiving information from all three systems there. I always give the example of, if you've ever been sitting in a car and you're sitting on a stoplight, a car's next to you and the car moves a little bit, and then you suddenly, like slam on the brakes again because you think that you're moving as well. That's kind of an example of where the visual system gave you an illusion that you were moving, but then the vestibular system actually came in to tell your brain you're not moving, because it doesn't sense any movement from your head or your body. And so then you all of a sudden say, oh yeah, I'm fine, I'm not moving. So that's kind of them interacting like they always are. All right, so I'm going to talk a little bit quickly about the first two, the visual and the proprioception, briefly, and then we'll get into the vestibular system. So from the vision side of things, anything that degrades the input, the visual input, can cause sensations and dizziness. This could be macular degeneration, cataracts, optic nerve issues. It can also be coming from how you process visual information. So this is like even binocular vision. So how well you use both of your eyes to track something, to look at something near and far, things like that. They can all affect your vision. So in a vestibular rehab assessment, we would be looking at how well you track, and you can look down here at the bottom. These are kind of some simple tests and a screen that we can see. So we wouldn't be testing necessarily your visual acuity, how well and accurate you see, but we'll see how well you use your two eyes together. And then if we see something abnormal, then we would typically typically send you to like a neuro-optometrist. Here is a funny little video of this cute little boy trying so hard to get his eyes to focus on that one little thing there. You can see him really struggling there and making all those cute little faces to really accurately get there. But you can see how that one eye struggles to get with the other. And so this would be a cause of dizziness. Okay, so next slide. So here we're just saying, anyone notice that when they're walking in the dark or when they're at the grocery store, anywhere with some very busy backgrounds, do they kind of feel that onset of dizziness? You see these people who are holding on to the grocery cart as they walk around the grocery store to help balance themselves because their vision, they're over reliant on their vision, and their vision is, you know, making them a bit dizzy. And this would be kind of an example of what I was just talking about before. So if that's you, can type me in the chat. There. All right. Good. We'll kind of move on here. So let's talk about proprioception. So that is that input from your joints in your neck and your feet are constantly sending information to your brain of where you are in space. This is really dominant on fixed and firm surfaces. I give the even example of, say you're out in the snow and it's pretty slippery outside. You kind of crunch your toes a bit in your shoes. And that's an example of your proprioception trying to get a little bit more information to your brain of where you are in space. You're also using those muscles to help you balance there. Good. There's also something called that's similar to that called cervicogenic dizziness. And this is the muscles and receptors in your neck. They are highly, highly innervated with your brain and your eyes. And so sometimes you could be giving false information sending false information from your neck muscles of where you are in space. And so this is more common of after a concussion, whiplash, things like that, where you've kind of really had some tightness through the muscles or some shortening on one side. In this case, you would say your brain, your inner ear is telling your head that you're here in the middle. And then your vision is also telling your brain the same thing. But then your proprioceptive system is telling your brain that this is middle. Well, then there's that disconnect between them. And so the brain kind of says, whoa, who do I believe here? Do I believe the proprioceptive system, the visual, and the vestibular system? So that can create some dizziness. And usually this dizziness is like a low-lying dizziness that people just kind of throughout the day say, I just don't feel that well, and I feel a little off, but it's not like that vertigo where the room's spinning, anything like that. So in this here, I'm not going to play the video, but just we do tests where we can have you put these lasers on your head, close your eyes, and actually turn your head and relocate to what you think is center. And we can kind of measure how off you are or know what's kind of abnormal. Oops, I'm gonna just move on here. All right, so who kind of notices that when their proprioception system is off? So when you're walking outside on uneven surfaces, does that make you a little bit more imbalanced than normal? So that would be a sign again of the proprioceptive system being off. All right, let's move along to my favorite topic, the vestibular system. So the vestibular system is a tiny apparatus that's located in your inner ear. So you cannot see it from the outside. It is deep in your inner ear. It's highly connected to your cochlea, which is your hearing organ. So there's 5 little tiny organs within the vestibular system that sense all day long balance and acceleration, movement, all those things, and send information to your brain to help you with gaze stability, postural stability, and orientation into space. So in terms of gaze stability, there's an actual reflex that's housed in your vestibular system that's super important. You use it all day long, and it's highly connected into your eyes. So what happens is, actually, let's do this. We'll have everyone put their finger out in front of them, and then you're gonna look at your finger, And then I want you to stare at the finger, and then you're going to turn your head side to side about 20 degrees to each side, and then try to go a little bit fast. You should be able to go very fast, 240 beats per minute fast, and keep that vision, that thumb in clear vision, but also the thumb should not move side to side at all. It should stay completely in the middle. If you had a deficit in your VOR, this reflex, then that thumb would start kind of shifting a little bit back and forth. And this is why these individuals complain of, when I move, I start seeing like my environment kind of do this, or they say, when I turn my head, it almost feels like my eyes have to catch up to my head. All right, so that's an important reflex there. Common vestibular symptoms. This picture on the side here is kind of what you would be feeling if you had a VOR deficit there. But typical is imbalance falls, vertigo, blurred vision, nausea, hearing changes, difficulty concentrating, headaches, motion sensitivity, and light sensitivity.
Jen, looking at that picture makes me dizzy.
I know, right? It's so true.
So when I did this thing, I didn't have that shifting, but that did make me dizzy.
Be dizzy,
so what does
right?
that mean? Yeah.
So that means that you probably have a little bit of a deficit that you should actually train and work on. So what we do, I'll show you in a minute when we go along there, what we actually do, but you can actually improve it pretty quickly if it's nothing that is just like, a slight, feeling of nausea.
Awesome.
So we're going to go into the number one cause of vertigo in the vestibular realm. And that is BPPV. It is a mouthful. It's called benign paroxysmal positional vertigo. You can see why we just call it BPPV. Benign meaning that it's not serious in that it's going to kill you or anything like that. Paroxysmal meaning that it is intermittent, it comes and goes. Positional meaning that it comes on with just certain positions. And then vertigo, you get room spinning, dizziness. So if you look here on this picture in the diagram, the otoconia are these little tiny carbonate crystals that sit inside that little organ there called the utricle. And sometimes, especially as you get older, these little carbonate crystals can actually get knocked off, sloughed off, whatever have you, and they start floating back into one of these 3 semicircular canals that you see on the diagram. So these semicircular canals are not used to having anything floating through them, but when they do, this is when you get vertigo. So typical kind of hallmark complaints here would be, I get room spinning vertigo when I lie down, roll over, basically anything that's gravity dependent, where you're going to shift these little crystals through this semicircular canal. And usually, typically, the vertigo lasts for about under 60 seconds, but it can make you feel really dizzy throughout the day. So I'll show you a picture here. This is what these little tiny crystals look like in your ear. Everybody has them. Just for sometimes they can get knocked off. You can see it post-concussion, post-head trauma, and it is very, very common as you get older. So it's pretty uncommon even up into your 40s, but then after you hit about the age 50, 60, you can see an exponential rise in your chances of getting BPPV. And that is because for 2 theories, one being that blood flow, the vestibular system is really very sensitive to blood flow. So as you get older, just peripheral blood flow is not as great as when you were younger. And then also vitamin D deficiency actually has been very proven that these individuals can get an uptick of BPPV with it. There's also a bit of a hereditary component. I see most people, I say, do you have, a family history? And they say, oh yeah, my mom, my grandmother has had it before, stuff like that. Okay, so.
Just a quick question. Oh,
sure.
Sorry, just a quick question, Jen. How many people over 50 or 60 have it? Would you say 1 in 10 or? Yeah,
so actually 50% of people, which is a very high number, over the age of 60 have it. And that even increases when you get into your 80s. I mean, it's like 70% of people can have BPPV.
Wow.
So I've actually been very surprised. I've even had people that don't complain of room spinning vertigo, but they're here for another kind of onset of dizziness. And I just do it in the in the appointment, and voila, they have it. And they had no idea that they're like, oh yeah, I had a little like room filling, shifting when I was lying down. But so it's very common. So how do we test for it? We put these really funny, goofy goggles on you, which magnify your eyes. I don't know if you guys can see me. I'll show you here. So these are our goggles. They have a light to them, but you put these on and they really, really magnify your eyes for us. So we can really see, because what we want to see is when we put you back into these certain positions to test you, if your eyes move in a certain way, then we can say, oh yes, for sure, we've confirmed that you have BPPV. So you have 3 canals on each side. So we test all 3 canals. So there's 6 different positions that we put you in just to see if we can see the onset of vertigo. And then from there, we can treat it. And we'll talk a little bit more about that later. I just want to highlight a few other vestibular disorders that are pretty popular: vestibular neuritis and labyrinthitis. They're very similar. One is just, it affects only the vestibular, so it doesn't affect your hearing. The other one, labyrinthitis, affects your hearing as well. And this is where you could have an infection, like a sinus infection, some kind of virus, bacteria as well, but mostly viral infections that actually get onto your vestibular nerve and affect it. These people would be more affected with that gaze stability that I was talking about. These are the individuals that complain of, if I turn my head, the room kind of shifts a bit. And then persistent symptoms post-concussion. Dizziness is actually the second most complaint in post-concussion syndrome, headache being the first. So we see a lot of those individuals. Vestibular migraine, which I spoke about before. Meniere's disease, this is a problem with the fluid buildup and actually getting rid of the fluid through the vestibular system. And then acoustic neuroma, this is a benign tumor that can grow on near the cochlea and the vestibular nerve. And then there's persistent postural perceptional dizziness. That's another mouthful. It's also called 3PD. This is individuals that have this rocking and shifting kind of sway, and it's almost like a hypersensitivity to all kinds of vestibular related issues. So like I was kind of saying earlier, the vestibular assessment is pretty complex. It takes about 45 to an hour to get through all the tests. So we're doing vestibular reflex testing, balance testing, the canal testing for the BPPV. We're looking at your neck and how it relates to your head, and if it's telling you your head the proper where you are in space. We're looking also at your coordination, and then your sensory integration testing, which is all 3 of those sensory systems for your balance, your vision, your proprioception, and your vestibular, and how they integrate together there. All right, so how do we treat vestibular dysfunction in rehab? If you have BPPV, we're going to identify which canal it is, and then we're going to use the correct technique to get rid of it. Success rate on this is very, very good. It usually takes 1 to 3 visits to get rid of BPPV. So it's very, very highly effective there. So that's great. People could self-resolve. So if they didn't come to vestibular physio, about 50% of BPP can self-resolve within 6 weeks. So you can either book an appointment and get it done quickly and be done with it, or you can kind of wait it out. And then there's also a chance that it might not self-correct there too. And then this is the VOR that I was talking about, Michelle, where you train someone, you actually give them just like an X on a piece of paper, have them look at it, and then they're starting to shake their head back and forth and look at the X. You want to go at a speed that you can keep the X still, but it's challenging. And this should maybe increase your symptoms about 1 to 2 like degrees on a 0 to 10 scale. And you keep doing that until your symptoms start getting better and better and better. But with people that have a disorder there and they actually haven't moved, you can't go to where it's moving. You have to almost stay at a speed that you can keep it very still. And then your brain starts recognizing that there's an error there, and it starts making improvements called neuroplasticity and helping improve that. And over time, it's actually really, really remarkable. And within weeks, people can start turning their head and can keep their gaze.
Awesome.
We don't need to see that. It's a long one.
Jen, there were a couple questions in the chat about BPPV.
Sure.
Can I ask those?
Yeah, sure.
Yeah. So one is, can cleaning your ear with a swab affect BPPV?
No, you can't get to it.
Okay. And can you get rid of BPPV through the epi completely, or just stop that one session?
So you can get it completely for that one episode. So say you get an episode of it, so the episode, like the one thing would be like 60 seconds long, but people would have it over and over again every time they went back into that same position, because that little crystal's still in that canal. With the maneuver, you will get it out of the canal where you're not going to have BPPV again. You can get it though within the same year. Like you have about a 30% chance of getting it again, or you have about a 50% chance getting it within 5 years, but you're just predisposed to getting it once you've had it one time, predisposed to having it again. But the maneuver will help with that, getting it out that, time.
And most even people, if it comes back again, you just get the maneuver again and you're good to go.
Exactly. And so a lot of times I say 1 to 3, because usually you get it on the first one. But sometimes because that you're kind of getting that little crystal back into where it's supposed to go. And then you have people go home, and if they lie back or, just stimulate it again, it could come back, but you just do the maneuver again. And usually by the second time, you've gotten it to lie down into that area. I actually have a model of, this is kind of what the vestibular system looks like. So this would be on the right side here. So mostly it comes in the posterior canal. So when someone, so it's housed in here, these little crystals, and they're supposed to stay in here, but with BPPV, they would come back into this canal. So you would almost have someone go here, and then I don't know if you can see here, these little crystals start coming down into here, and this is what stimulates you to get vertigo. You can do these maneuvers where you get all of these back up into the utricle, and then they stay there. But you have to make sure that they all get back in, because there can be multiple of them. If you can see here, you need to get all of them back in. And that's why it takes maybe 1 to 3 visits to get them all back in.
That makes a lot of sense. Thanks.
Yeah.
Sure. And then balance training. You're going to hear a little bit more about this from Christy, but we're just kind of taking it from a soft surface to visual changes and dynamic dual tasking, having you talk and do all kinds of juggling acts, all that good stuff. And then patient education, most important. At the end, we spend a lot of time talking about assessment findings, treatments, referrals. If you need any referrals that we saw something to that day that was abnormal or out of our scope of practice, that we want to make sure that we clear through a doctor, neurotologist, stuff like that. And then we also want to refer out to, if you're doing really, really well afterwards, but you still want to work on specific goals, referring out to like a personal trainer like Christy to keep you strong and keep you kind of working towards your goals. So then let's talk, let Christy talk a little bit about what she does.
Okay, thank you so much, Jen, for that amazing presentation. A lot of detail there for people, as well as us trainers too. I think it's a great evaluation you gave. They're going to get an evaluation to be able to assess their dizziness, and a lot of information to be able to self-assess. And it's great for us trainers to know when there's something is not quite right and we need to refer out. So amazing presentation.
Thank you.
Yeah, ultimately, optimal balance is functional movement, ultimately. So, you're able to move through life functionally, do all the things that you want to do and feel good, and you don't have anything restricting you, basically. So training functional movement or having optimal balance means having optimal range of motion and stable joints and muscles. So basically I wrote static and dynamic. So you want to have range of motion and stable joints and muscles, not just in a standing posture, but in a moving posture too. So sometimes people can move their arm quite far, but then when you're actually going to pick something up or you're moving, you know, your range shortens down, like reaching up to grab something out of the cupboard. You know, you might not do full range of motion. So it's important to do full range of motion, standing and moving. To have optimal endurance. So to have functional movement and optimal balance, you want to have endurance in key muscles. So I indicated the back. So the muscles that run along your spinal erector muscles, they're endurance muscles. We'll call them slow twitch muscles. So they can withstand long periods of time rather than short, powerful muscles. They're more long and slow. You know, you can use them for long and slow periods. Your core muscles, like your transverse abdominals, that's a deep muscle in your core muscle. That's an endurance muscle. Your hip muscles, the endurance muscles there would be your pelvic floor muscles and your glute med muscles on the side of your hips. Those help endure you there. And then the ankle muscles, the soleus muscle is deeper than the calf muscle. So that is also endurance muscle. So these endurance muscles are usually deeper. They're not superficial. They're not a powerhouse muscle. They're what keeps you maintaining your endurance, slow and steady. And they're made up of slow twitch fibers. So they're meant to be postural muscles and balance muscles, basically. And then you want to have optimal strength. So predominantly when we're talking about balance, we want to have mostly a lot of strength in the lower body so that we can maintain this balance, this sense of balance. And of course, you want to have optimal coordination. So that neuromuscular control about your brain telling your body when to move and what movement to do to get the task done. So all four of these are important for having optimal balance and functional movement. As a trainer at Vintage, I specialize with people. I specialize with seniors, helping them move functionally so that they can move through life easier and have more confidence in doing so. And I also have lots of balance with, I also have lots of experience, excuse me, we're talking about balance so much. I have lots of experience dealing with people with chronic conditions and disorders, as well as common postural dysfunctions.
That's great.
So this is where I wanted to just have a little bit of fun and maybe ask the participants to stand up and give each one of these a try. So this is examples of balance tests that I would do, as well as some balance training that we would do during our session. So I just ask that if you do stand up, that you make sure that you have a wall or a chair close to you in case you lose your support. Our sense of balance, so you can quickly grab something. So I'll just talk before we stand up. Basically, you ultimately want to narrow your balance, your base of support. You want to narrow your base of support in a static, so in a standing position, as well as a moving position. Obviously, moving would be more challenging. You want to create more instability by moving, maybe your limbs, moving your head. And then the third one is you want to create even more instability by adding like an unstable surface, for example, like a pillow or, walking on an uneven surface. So these are all examples of proprioceptive balance, which is what we're talking about here. So let's give it a shot, one of each. So I'll just stand up to demonstrate, and anyone would like to come and stand up with me,
I'm going to stand up and do it.
Okay, great. So the first thing that I'll just talk about actually is we have 3 points on our feet, which are called base of support, which is our big toe, our baby toe, and our heel. And so you really want to, in order to have good balance, you want to have your weight centered on those 3 areas. So think of your foot like a triangle. Okay, and so we'll do weight shifts as the example of the first one. So we're standing here and we want to basically, you can see my lower body. So I'm just standing hip width apart, and I'm thinking about shifting my weight to the big toe. Now I'm thinking about shifting my weight to the baby toe, and now I'm thinking about shifting my weight to the back of the heel. And just go in this order. You can go clockwise, you can go counterclockwise. And if this is feeling fairly good, then you can always increase it by maybe standing on one foot. And then we could try shifting our weight to the baby toe, to the big toe, and then back to the heel. So this is an example of narrowing your base of support. Weight shifts are usually the first test that I do for people, because if you're about to fall, you're going to shift your weight and you're going to need to catch yourself. So it's a good test as well as a training tool to be able to practice. The next one we'll do about creating more instability would be to stand up on one foot, and you don't need to stand up on one foot. You can keep both feet down and do this example as well. But let's now maybe move our arms, right? So let's bring our arms up and down, in and out, sideways, up and down again, in and out, sideways. And I'm standing on 2 feet for those people who feel that they need to stand on 2 feet. If you want to do this on 1 foot, you could also challenge yourself as well. So the goal here is basically that you're moving your limbs around and you're adding more instability to the exercise. And then the last example will be, let's all just maybe grab, if you have a pillow nearby, and if you don't, not a worry, you could try it later. But basically, if you were to stand, let's say on a pillow, and I picked a pillow because it's something that everybody has around. So if you were to stand on the pillow, again, make sure you're close to something, and you were to stand on that pillow, you're now on that uneven surface, okay? And that's more challenging. And you could do the exact same movements, standing on 1 foot, focusing on 3 points of contact while moving arms on the pillow. And that's very challenging. So those are examples of some tests and some training that we would do.
I love that, Christy. Even with the foam pillow, like I use that often because it's throwing off people's proprioception. And then you even do an eyes closed. Then the person has to actually rely on their vestibular system to help them balance, because now 2 of their systems, one is a little faulty and then the other one is completely gone with the vision. So it's great. I love that. You're even doing vestibular.
Yeah, I didn't even know it exactly. So yeah, as you can see here, there's an example of progressions. Yeah, and they just go on, just gets it even harder. We didn't get to the eyes closed one, but that obviously is a great progression. So.
Yeah, that's awesome. Very cool. All right, so now we're going to kind of end things with 3 things that you guys can do now to assist with conquering your balance and vertigo and get you back to doing the things that you love. One is knowing your dizziness checklist. So the checklist that we talked about at the beginning, at your leisure, download it and kind of fill it out. That way, when you do want to talk to someone about dizziness, you have the accurate kind of verbiage for describing it. So that will be coming in your dizziness guide that you'll be getting later today. Also, just finding support and resources. So VEDA, which is the Vestibular Disorders Association, has a full website full of information, chat rooms, support groups, resources that can really help anybody experiencing any kind of imbalance and vertigo. Don't worry about remembering that. That's also going to be in your e-booklet today. And also Vintage Fitness, is another amazing company that we have locally that is here to help you stay fit and balanced while you're working on specific tasks tailored to you. And then last but not least, take action and book an appointment to come see Christy for personal training or myself for vestibular. And now 2 ways that you can get started. You can simply type, if you want to get started now, is simply, you can type scan in the chat. If you want a free 15-minute scan, this can be a phone call or virtually, to help you kind of tips on your specific needs and wants, and also answer any unanswered questions that you had today that you felt a little bit uncomfortable about typing in the chat. We can do a scan to help you. And then there's also, you can type assessment, which is a one-on-one assessment with Christy or I. And this is a comprehensive exam tailored to, this involves treatment, home exercises that are more tailored to you and your goals. So now you can go ahead if you want. You can type either assessment or scan in the chat and just put beside it Christy or Jen. That way we know who to contact after this. So we'll follow up with you later this week and get you scheduled in for an appointment. All
and
right.
If you're not sure what you want or need, you can just type that in and somebody will reach out to you to talk to you a bit more.
That's right. And then we'll open it up to questions now, if there's any other questions that anyone has.
So Jen, there was something in the chat. Can gait issues affect balance? And in brackets, from an Achilles tendon injury?
Of course, absolutely. If you think about the Achilles tendon too, like you're getting all of this information from your proprioceptive system, from the joints and in your ligament there. So you definitely, if it's altered, you're going to definitely get issues with balance.
Can that be improved? Like, is there anything he could do about that?
Yeah, so you want to really address the cause. So with the Achilles, try to get the muscle length tension ratio kind of back to its normal, optimal level. And that will also help with the balance. But you can also train your proprioceptive system. If it's something that's not correcting, you can train it to actually start sensing, with different, like with a foam pad and with other systems and treatments, you can definitely do that.
Excellent.
We see that often.
Are there any other questions? I'm looking through the chat just to make sure that we answered everybody's questions, but as everybody's sort of just typing in the chat about the assessment or the scan, does anybody else have any questions they want to ask?
Michelle, I just noticed another one. Can you get rid of BPPV through the EPLI completely, or just stop that one session?
Yeah, that's that you can. So you can definitely get rid of BPPV through the EPLI.
Great.
So it depends on, I'll just say this really quickly. So a lot of people they go online, they have BPPV, they go online and they just think that, so EPLI is just one of the ways you can treat BPPV, but you have to have it in the posterior canal and you have to figure out which side it's on. So a lot of times people say, oh, I was doing the EPLI, but it wasn't working. It might be that the crystal is not actually in that specific canal. So you're doing it, but it's not, actually getting it back into that little small utricle. So you have to really make sure that you know which canal it's in to be able to treat it. And it may be the EPLI, most of the time it is, but you also need to know what side it's on.
So I guess that's why you shouldn't try the maneuver at home, because you might.
Yeah, I've seen more what they call canal conversions than ever before, because especially at the beginning of the pandemic, we're all stuck at home. So people are trying, online, and they're actually going back and almost making it worse because they think it's in one canal, but it's in another. And then the crystal's going, So yeah, it's really good to know which one it is in.
Good. And can you see people virtually, or do you have to see them in person?
Yeah, so you can see them virtually as long as they have access to their phone, because with the EPLI, if you have vertigo, we want you to be able to bring the phone back with you, because I need to see your eyes to be able to assess if that's actually what it is. So you just need that, or have someone that can take the iPad or something and go back with you. But yeah, of course.
Great. Awesome. Any other questions from anybody out there? Did we answer everything? I hope we did. But please type in the chat if you have any other questions. Jen, I noticed when you were asking the questions about people sort of feeling that wonky feeling on uneven surfaces, there were quite a few people that were experiencing that. That seemed to be the most common thing.
Yeah. So that is very also easy to train. So really trying to get your proprioceptive system to increase the input. So those three systems that you have that for balance, a lot of people are actually overly visually dominant. So they use their vision so much that the other two systems actually don't get interpreted as much. When that happens, and when they go on these uneven surfaces, the proprioception system and the vestibular system don't really know how to act. And so you have this increase in dizziness. So it's all about sensory reweighting your sensory systems to help with that. And that's really easy too.
Good. So we have another question. If you have BPPV in one side, is it always on that side? I was diagnosed at the hospital and it always seems to be on that side.
So it's easy because when you know it's on that side, you kind of could do the Epley at home if you always are getting it on that side, but that's definitely not the case for, like, I would say most people. I just had someone yesterday who I'd seen a year ago, and she had it on the left side, and then she was so surprised because she had it on the right side this time. So it could be yes and no to that question.
Keeps you guessing every time.
Yes.
I only get it in the morning. What does that indicate?
So if you only get in the morning, it's probably just because you're coming up from that position. During the night, these little tiny crystals have time to fall back into where they're supposed to go, where during the day, you're not staying back here for long periods of time if it's your posterior canal, or going forward and like doing anything except for like tying your shoes or something like that. So that's why most people get it in the morning, because they've been lying like that all night long. They're all coming down, and then they get up to go sit up and they're like, whoa, the room is spinning now.
Amazing. I actually didn't know that.
Yeah.
That's amazing.
We also see a very increase when people go to have like a dental procedure done, because they're staying like that for long periods of time.
Yes.
Getting their hair washed at the hairdresser, same kind of thing. You're staying back there
Yes.
for a long period of time.
That makes a lot of sense. There's one other question here. Once you've had vestibular disease, have had treatment, 1 to 3 sessions, are you predisposed to getting it again?
It depends on what kind of vestibular disease, but for the most part, I would say yes. Vestibular disorders almost come into, like, if you have one, you're likely could possibly get another. You're more likely to get it versus someone that's never had any vestibular thing, especially BPPV. I find a lot of people who had vestibular neuritis before, and then they get BPPV. People who have a Meniere's disease, and then they have these onsets of BPPV, stuff like that. So they do kind of coincide occasionally.
Okay. And is there often a family history? Like, oh, my mom, my dad had it, now I have it.
Yes. So there's been a lot of research, because they don't really know a huge amount of why, like an exact why BPPV happens, except for those 2 kind of things that I was telling you about, the vitamin D and the blood flow. So, but I usually, anecdotally, like, ask people, oh, do you have a family history of this? And I would say 60% of the time, people are going to say, oh, yes, I have so-and-so and so-and-so. But there's research behind that too, that says that there is a small component of genetics.
Makes sense.
Yeah.
Awesome. Any other questions before we wrap up? Anybody out there? Did we answer everything? Any last questions?
Thanks everyone for attending. I hope
yes, thank you to everybody. You're welcome. For all of you that have said thank you in the chat. It was a pleasure to have you all here.
Yes. Perfect.
Awesome. All right.
Oh, you know what? We forgot to do spin the wheel.
I was just
gonna spin the wheel. Shoot, I forgot. Oh my
goodness. Guys, we also have
don't leave, everybody stay.
Spin
the wheel.
If you want to hang on very quickly, we're going to do something called spin the wheel, where we're going to put all the names of all the attendees in the wheel, and 2 people will win. One person will win an assessment with myself, and another will win an assessment with Christy. So just hang on, and I'll stop sharing so we can let Zena do spin the wheel. Okay, Zena, you should be able to go. Or I can't believe we forgot about spin the wheel.
I know. I think we'll make an exception this time. Normally we don't like give it to people unless they've made it to the end. But this was my fault, our fault. We should have done it sooner. So even if they're not here, we'll still
Perfect.
We'll still let them know they've won.
Yeah, no, for sure. We'll reach out to them.
Yeah. Heidi.
Yay!
All right.
Perfect. All right.
One more time for another winner.
All right, here we go.
And Linda. All right. So Heidi and Linda, we will reach out to you. Congratulations. We'll reach out to you and get that arranged for you.
Perfect. Well, thank you, everyone.
Thank you so much.
Yeah, thanks, guys. That was a really great presentation. So
Thanks,
informative.
Christy and Erin.
Jen.
Thank you guys so much.
Thank you for having me. It was wonderful. Thank you.
You did amazing.
It was great. You guys did a great job.
Awesome.
Super informative. Very good.
Okay, so I will download the chat before I
Yep.
forget.
Good idea. We said Heidi and Linda R. I didn't get the full last name. Zena, do you have the full last name? Oh, Zena's gone. We'll get it from her. Did you guys catch her last name?
I think it was R.
Yeah, it was something like that.
Rossner.
I think. Yeah.
And Heidi Prentice. And then, new message. Oh, just people saying thank you. That's good.
Okay,
We were able to help some people.
Save chat.
And Jennifer, if you could just, it didn't let me record. If you wouldn't mind sending me that when
sure.
it downloads, that would be great.
I think what will happen is I think I'll get a notification when the recording's ready. I think that's what I usually get with all of these things. So when I get that, I'll just forward it to you.
Awesome. Thanks. Yeah, that was a
And did
really
you
good
get access-
presentation.
Yeah, it was great. Good job, guys. You really did a great job.
Yeah.
And Erin, you've had access to the registration form. Has that been okay?
The
registration, the names, the spreadsheet. With all
Oh
the
yeah, I'm not sure if I have that now, but I can relook.
Yeah,
I'm
take
sure
a look. If you don't have
Yeah.
it, just let us know and we'll reshare it with you. No problem.
Okay, that's great.
All right, perfect.
Good. Okay, and then I'm wondering, so we've got these two names and it was one assessment from each of you. So who would like to read, like, how do we decide what was the first spin for you, Jen?
No,
or
however you want to do it, doesn't matter to me.
Doesn't matter to me.
I mean, one idea, some people asked for a scan. So if one of those asked for a scan, it might make sense for them to do
Oh yeah,
it
that's
with you, Jennifer, because obviously they want the, because but probably.
Okay. All right, so we'll get all of that going. I'll get Zena working on getting the email out and all the usual sort of post-workshop.
Perfect. And then also, Erin and Christy, when I make phone calls tomorrow, if anybody is interested too, just on the phone call for, I'll make sure to connect them with you guys too, because we just make phone calls just for people who didn't type anything, just to make sure that they're fine and they're have all the information they need. So I'll connect them to you guys.
Yeah, awesome. Good. All right. Thank you, guys. That was great.
Thanks.
Bye, everyone.
Sorry,
Have
Jen,
a good day.
You downloaded
Okay,
the
bye.
chat, Jen?
I did.
Okay, good.
All right. Bye.
All right, bye, guys.
Bye.
Bye.